So here we go, guys. This is the last training, session 4, and the Bach leadership team has been fantastic in creating protected time for you all to attend this and to train up. We hope that this has been fun for you all. Just remember to starve your distractions, feed your focus. Thanks, Dr. Ramchandani and Katrina. The more you put in, the more you get out. Today, we're going to wrap it all up. We have the obligatory CME stuff and CEU stuff. So remember, if you want CME and CEU, there is an important survey to do at the end. And we'll create time for that. You all know who I am, Stephen Chen. I'm the Chief Medical Officer, Family Medicine Doc by training. And then Dr. Daphne Miller will be joining us. She's coming from clinic as well. She's at Lifelong. She's also a family doc as well.
I'm here. So sorry, I was actually just finishing up Dr. Chen's wonderful recipes for health that he started. Hi,
Great.
Everybody.
Thanks, Daphne. Good to see you. She's running a group as well now at Lifelong, a Recipe for Health group. Great. So we have some educational objectives. I'm just going to go through them. The key one has always been the same at the top. Increase your skillful use of food as medicine to treat, prevent, and reverse chronic disease in a one-on-one clinical encounter. That you are set up in your 15-minute visits or 20-minute visits or 40 if you are a coordinator. Thanks, Judy, for being here. Dr. Jimenez is here. Wow. Today, we're going to cover 3 elements of mindful eating, one of our 6 steps to address hunger and satiety. We talked about hunger and satiety last time. We're going to utilize 2 elements related to meal consumption. This is one of your 6 moves that you can use with your patients. We're going to describe the evidence behind 6 different common eating patterns. We just think it's important as you enter the space, as you start reading the literature and understanding what's in the social media, that there's a sense of what are the eating patterns out there and what's some of the key evidence behind them. It's not going to be exhaustive, but a good beginning. And then we've talked a lot about the 6 steps. And so it'll be really about combining the 6 steps on the spectrum of nutrition interventions that are likely to produce health out benefits and to customize that for each of your patients. We'll be doing cases together. And then at the end, we're going to bring it back to this work together and what we're doing in this partnership across the county, where we will combine principles related to where we focus, human health, but connected to the planetary health piece in thinking about our patients. The 6 steps are here, and it's organized in the when, what, how. This is really what hopefully you'll have in the back of your pocket when you see patients at 1 o'clock today, that you have 6 different moves you can take, and that you take a motivational interviewing approach and see where does your patient want to start. And so we'll be going through each of these today. We've gone through 1, remove sugary drinks and replace. You'll see this remove and replace concept. We've gone through 2, remove processed carbs, replace with a lot of the veggies, legumes, pulses, whole grains. Number 3, remove and replace the processed stuff, processed meats, fats, and excess salt, and replace with the unprocessed meats, fats, and spices. And then shorten the eating window and the frequency of eating. That's what we did today in the last sessions. And today we'll close it out with 5 and 6, the mindful eating and the minimizing meals out and maximizing meals in. So how to eat. Your patient may not want to start with what to eat. Your patient may not want to start with when to eat. Your patient may say, I can try how to eat. And I'm going to turn this over to Dr. Miller to lead us in this section. We can't hear you, Dr. Miller.
Good morning, everybody. I hope you're maybe grabbing a little bit of lunch or something as we're doing this, because then we can actually all do this exercise together. But there's actually really good evidence that the stuff that we do before the food actually hits our stomach might have rather interesting impacts on our health, both in terms of how we digest the food, how we jumpstart our metabolism, what our insulin levels are, what the ghrelin and leptin levels are, which are these hormones that both inform our appetite, but also tell our brain when we're full. And so I call these parts of eating the 3 C's. And they really are kind of the pre-swallowing parts of eating. One of them is really in how you cook or compile or just assemble your food. The second is contemplating it and really, what does it look like? What does it smell like? What does it sound like? And the third is chewing and what that experience does to your digestion and your experience of the food. And these are important both, for just our aesthetic and pleasure centers and, enjoying what we eat. But they also seem to play a role, as I said, in metabolism, in controlling our blood sugars, and in impacting our digestion for people who have things like dyspepsia or constipation or dumping syndrome or things like that. So 3 important C's. Next slide. A wonderful exercise to start to have patients tune into the 3 C's is something that was actually developed by Thich Nhat Hanh, the amazing philosopher who actually died this year, and Jon Kabat-Zinn, a psychologist who's written a lot about mindfulness in general. And it's actually Thich Nhat Hanh wrote about it originally with a slice of mandarin, mandarin orange. And then it's sort of been adapted with a raisin because that's sort of more universally available. But does anybody have a little piece of something tasty with them right now? Let's actually move away from the image and go to the stop the slide share and see if does anybody have. Oh, Mila has an orange. Is that an orange that she and Celia has a raisin. Sangeeta has something that looks good. I can't see what it is. You guys can share. And a slice of something. And yeah, so pick something, just a little small piece of it, and put it in the palm of your hand. I love Sapna's got a piece of cheese. Anything will work. It doesn't have to be. Ronaldin has a piece of cheese I'm seeing. Wonderful. I'm sure that other of you have something. Take a piece of it and put it in the palm of your hand. And the first thing I'm going to have you do before any of it goes in your mouth is actually just kind of look at it. Contemplate it. Think about what it might smell like. Think about what it might taste like. Think about, maybe where it came from or who made it. Was there any love involved at all for some of the things that we eat, like a farmer growing it, something like that? Okay. And then take it and give it a smell. Do you smell anything at all? Not so much in Sapna's plastic wrapped cheese, maybe, but somebody getting a smell from something they have? Not when you have your mask on. I know it's hard then, right? Jon Kabat-Zinn suggested that we touch it and listen to it even. See what it sounds like when you squeeze it like a raisin. Yeah, and then the next step is to actually put it in your mouth and start to feel. Dr. Chen has something in there that looks good, and see what it actually tastes like on your tongue. Okay, and your tongue has receptors both in the front and then the more intense receptors that are there in the back. So before you even start chewing, you can actually start to get the taste of your food in the back of your tongue. And believe it or not, just in these processes, your pancreas is already starting to decide to release insulin to respond to the food. It's also releasing those two hormones, ghrelin, which is, increasing your appetite. And it's also starting to program the leptin, which is kind of the back bookend, which is going to tell you that you're full. So all these messages are actually starting in this pre-contemplative place. And the more that you chew, the longer that you chew, the more that you give a chance for your body, your stomach to catch up in terms of digestion and to get the appropriate peristalsis moving, the appropriate hormones released, to have gastrin released so that it can actually, the food can be broken down in the stomach. And gastrin also tells the large intestine to start that peristaltic wave. So there's this whole cascade that happens even before the food goes down your esophagus and hits your stomach. And a lot of times when I'm working with patients with GERD, with irritable bowel, with dyspepsia, and certainly for folks with diabetes or different kinds of metabolic issues, working on those 3 C's is actually a great place to start. Back to you, Dr. Chen.
Thanks so much. That was great. I'm going to flash the screen up again.
Does anybody have a question while we're going back, or comment about that experience or thoughts? We're going to show you a little bit of data to kind of support this right now, just for those who are a little, for whom this sounds a little bit woo-woo. The next piece was portion size. I guess it is still me. Along with those 3 C's of compile or cook, contemplate, and chew, another way that we can actually start to work with our kind of pre-digestion self to kind of control appetite and so on is through portion size. It turns out that the size of the plate seems to hardwire our brains a little bit to inform the size of our appetites. So the bigger the plate, the more food we take and the hungrier we feel. It's sort of interesting. And if you look at a lot of cultures that really have traditions of sort of eating healthful, tasteful foods, but in small amounts, for example, a lot of Asian cultures, the dishes are really small. And even for the decadent stuff, like the white rice, it's generally a pretty small little bowl. And so I just put here my 3 plates that I have at home. The bigger one is 11 inches wide. And then the smaller one is 8 inches wide. And then that little bowl is 5 inches wide, albeit a little bit deeper. And so, in general, my recommendation is to stay with those 2 smaller sizes, and for us to advise that our patients stay with those smaller sizes, because it seems to actually help people have a portion size that more matches what their body needs. And then they can always go back for seconds once they wait those 20 minutes and see, register whether they are still hungry once they finish what's actually on their plate. There's a link here to a study that was done in 2013. It actually was a randomized controlled trial that was done with children looking at plate size and how much they ended up eating, both in terms of volume and calories. And it was highly correlated. Obviously, it wasn't a blind study because they could see the size of their plate. But there seems to be a very strong correlation. And these same studies have showed up in adults as well. So any thoughts or questions there about the 3 C's or about plate size as important ways of also helping folks stay more connected to what they're eating? Is anybody already using these techniques with their patients? G Payne says yes. Wonderful. Any additional techniques that you're using, G Payne? Other thoughts? Okay, so moving on to portion size. Is this me or you, Stephen?
You can keep on going.
I keep on going? Okay, so oftentimes patients will ask me, how much should I be eating? And there's lots of systems out there for helping patients stay in touch with that. But honestly, most people have at least one hand, and it is this thing that's kind of always with you. So probably the best thing to use. And it's really quite proportional, whether they're a child or adult. So what I usually tell folks is that your fish, your meat, your nuts and legumes occupies kind of the palm of your hand. The grains is from the sort of MCP, the first MCP, fold. And then the oils, the cheese, and the butter is kind of the volume of the thumb down, is a useful way of thinking of it. And then vegetables is basically your two hands with, you only have one hand there. Oh, that's different than what I usually show folks. I usually show folks two hands, like a big equivalent two hands of veggies and fruits. So.
We had talked about veggies last time in terms of serving size, what is kind of the definition of the serving size, and then what we do in clinic. And the purpose of this section was really just to identify simple ways to make it accessible to your patients, a fist or, the palm of your hand, and utilize these elements just to make it real. Thanks, Daphne. Again, the 6 here. So we just really went through 1 through 5 now, number 5, and now we have number 6. I'll turn it back to Daphne to close out this section too.
Meals out is can be another marker of kind of dietary well-being and even metabolic health, and is something that's important to assess with our patients. And we tend to think of meals out or unhelpful meals out as mostly fast food, or what we classically think of as fast food. But the truth is that meals out in general are a time when we have less control over ingredients and additives and portion size. And so it's, a lot of the research shows that regardless of income or types of meals out, that there is this negative correlation between well-being, body weight, and meals out. So more than 0 fast food per week, or more than 2 of takeout or restaurant meals is definitely at least an indicator of sort of being more at risk for having a poor diet, and certainly for a high BMI. Does anybody ask about meals out with their patients, exploring this in some way or another? And if so, what is the question that you ask? If you'd be willing to put it in the chat, that would be great. How do you ask the question?
I suspect that folks may not often use this question and think about it, right?
Yeah, I'm wondering if maybe not. I just wanted to give a sec to see, but yeah. So one way to ask frequency of eating out, says Mila. Okay, yeah. So one way to ask is in a given week, how often do you eat out, says Marjorie. Yeah, how often do you eat out? And that includes fast food, takeout, restaurants. Are there other things that we should be putting on that list these days? Probably order in too, like Grubhub, things like that, so people can think about that. Yeah.
Frozen foods.
Well, it's interesting. Frozen foods actually are in a different category, because we really do have this explosion in the market of kind of pre-made and frozen foods. I'm gonna it is here somewhere. My lunch today, I'm ashamed to say I was late, and sometimes I just grab things, but I have an ancient harvest pre-pack here with quinoa, and that actually has an incredibly clean label. So, you know, and this was in my freezer. So, so I think that that can be more challenging for sure. But definitely fast food, definitely restaurant and takeout, DoorDash, says Mila, Uber Eats, and so on. And these are things that we often do not assess with patients, or we just ask about fast food like Burger King and McDonald's, and don't actually focus on other things. And what was so interesting to me about this study, it's an old study now, but it really showed that more meals out is a risk factor for, you know, diabetes, heart disease, obesity, regardless of socioeconomic status. So, you know, presumably folks that have more money and are maybe eating in, you know, fancier establishments are still not having optimal nutrition by eating out more than twice a week.
You know, I'm going to add something. I have family members that are in the chef restaurant business, and they're well-trained cooks and chefs. But when it comes to nutrition, may not always know as much about that, although they make the food taste great, right? So, and then certainly what us in medicine, we often don't know really about the food prep or the compiling and all of that. And so there's really opportunity to do some integration in that space.
Yeah, and of course there are restaurants who are complete exceptions to this, where people really do feel like, you know, there's this, you know, approach to the ingredients and prep that is, you know, as healthy or more so than they could possibly do at home. So this is a generalization, but it does seem to transcend, you know, sort of the cost of the meal. So there's a lot of fancy meals that are also not good for us. I just put this on there because this was something I used to show patients in my clinic as sort of a way for them to start to wrap their brain around what happens when you eat out. And I would show them this list of ingredients and ask them to guess what they thought this was, what meal they thought this was. Does anybody here have a guess? I'm looking in the chat.
Chips. Chips.
Chips, close. Any other thoughts?
There's cornbread. Somebody put cornbread, tortilla
corn chips, said Ronald. Yeah. So yeah, so why don't you show them the answer? Yeah, it's lime seasoned nachos from Taco Bell. It's their recipe for lime seasoned nachos. So which was a huge favorite a couple of years ago. But you know, when people look at, oh my gosh, what are all those things and what are they doing in there? And I could make nachos at home with lime and some clean tortilla chips and a little bit of cheese and have it have like 3 or 4 ingredients. Next. This is another interesting study that was published in Appetite that looks at how some of us are more sensitive than others to eating cues when we get into the fast food restaurants. And what this study showed was that among folks whose BMI was normal, they actually tended to take in fewer calories overall and, you know, just less food when they were not in their home environment. So when they went out to eat. And interestingly, for folks who at baseline were overweight, when they went out to eat and went into a fast food environment, they tended to eat a lot more than they did at home, more calories. Now, what is the explanation for this? We could probably come up with many different explanations. Does anybody have a thought? I'm looking in the chat again.
Is it because overweight people, they were trying to cut down at home, and when they go out, that's like a time to enjoy or indulge?
That is a really great explanation, honestly. That might be a piece of it, that they get a cue from eating out that it is more of a celebration. And as compared, more food choices, said Ronald, and yes, that's another cue. Yes, and the menu looks appetizing. That's what the authors actually postulated, was that for some people, they're actually more susceptible to all those messages that happen to like buy more, eat more. And that's what they sort of, when they did the exit interviews, that's what the subjects were saying, that they just were having a hard time following their own inner messages when they got into these environments. So it might be that part of what goes in to some folks, having more challenges controlling their weight, is that they have a little bit more of a challenge sorting out these cues as well. And the eating at home is a more healthful location for them. So hard to know what's chicken or egg, but it's an interesting thing to contemplate. And step number 6 was minimize meals out and maximize meals in as well. This is also part of step number 6. And I included this photo because about 10 years ago, a little more now, I was actually asked to be a visiting professor at the University of in Okinawa in the medical school, Chubu Medical School. And ironically was asked to come there to teach nutrition in the internal medicine department. And the reason I say it's ironic is because I don't know if you're aware that amongst the older people in Okinawa, they have some of the longest lived people on earth, the octogenarian, the over 100 set, the what is it, dedecanary or whatever.
Centenarians, right?
Centenarians who are just famous for their healthy eating. Centenarians, thank you, Ronaldin. I'm having a brain blip here. And so I actually lived with this one family, and Dr. Chen knows this family as well, because Kenji, who's on the far right, was an emergency room doctor that we did our integrative medicine training with. And what amazed me was that they all, the adults all worked, the kids were all in school, they were all going in different directions. Kenji spent long hours in the emergency department, but every single breakfast and every single dinner, they had family meals together, and these beautiful kind of cooked meals, and everybody assembled and ate. And what I noticed was just how much the children enjoyed the vegetables, how healthy the family was, and how much it connected them. So I just wanted to include that photo because that time was so inspirational for me.
Thanks, Daphne.
And that's you in the picture, Daphne.
That's me.
Green.
That's a much younger me.
Same.
I always joke that the one who looked a little bit like the oddball, the Where's Waldo.
That's great. So big deal, you often hear that people say, hey, if you eat as a family together, there's a lot of other co-benefits, right? And so this is just crystallizing that experience, and Daphne got to live that with our host family. So I want to do a check-in with you all. And this is an opportunity for us to talk as a team. What are you doing differently already? We've been together now over about 4 months. And what is one change in your practice you will try on within a week as you think about some of the things that we've learned together? So I'm going to end the video or the PowerPoint and go back to gallery view if folks can come back on. What are you doing differently? And then what do you want to try on differently? And then we're going to use this as a way to lubricate the next part of the conversation. Anybody want to share?
Hi, this is Trishna. Sorry, my camera's not working. I'm not patient-facing as much as I would like to be, but in my personal life, I've changed the oils I've been eating. I've added a little bit more whole grains. I'm looking more at the labels, which I knew already, but I think it motivated me to do it more because it was so, when you taught us, you taught us like on a micro level. So it kind of helped me, dissect what I was doing and eating. So it's helped me a bit.
Thanks so much, Trishna, for sharing that. I think that key piece is important. We're teaching you at a level of granularity that we hope is applicable, right? It's always great. It's always nice to tell someone, oh, just do this. go eat more healthfully. But then like, what's that actual next step? What do you mean by that, right? And so that's what I'm hearing from Trishna. Dr. Jimenez wrote in, encouraging identification of what they are willing to start working on diet-wise. So really identifying, having the patient identify what's important to them and starting with that. We're so used to, as clinicians, just telling people what to do, right, in these vulnerable moments, and then thinking that's the end, that's it. They're going to do it for the next 4 months when we see them. When we know all the data is clear, when patients choose for themselves what they're going to do, and we help guide and steer and support, that adoption lasts longer. Erica put in, doing more 24-hour diet recalls with patients to talk through what replacements they can make at home. Absolutely, it's always great. It's good to know where the patients are starting from. And you'll start noticing when you do this that, if a patient tells you they do this, there's a lot of regularity to what we eat. Not always. We're not totally, going off 5 different approaches. Many of us kind of get into patterns. And so you can get a glimpse of the pattern. Other things you've been trying on for yourself, your family, or for your patients. Sangeeta writes in, reading labels. And we try to simplify reading labels, kind of like X-ray reading, stepwise. Sangeeta, as you've been reading labels, is there something you want to share? Any ahas about some of the foods that you didn't know about before and now you know more about by reading labels?
The sugar part. So as you mentioned, it's like the 4 grams. So how much teaspoons and how much grams of sugars are there and how much calories and what is the fiber content, added sugar. Those are the main things we are looking into it.
Yeah. Yeah, I love using the added sugar one. It's just an easy way to start, right? And then for my diabetics, sometimes I will move up once, the added sugar is minimized. I start looking at total sugars and the impact of that. I'm seeing that Dr. Jimena wrote also finding out what triggers them, right? That was there's an acronym we use, but stress, hunger, loneliness, all of those pieces. Absolutely. Anything people want to try on this next week? Maybe something you just learned from Daphne. Mila put, I acknowledge more this time my patients' challenges. Sometimes they will not express it, but I always have more encouraging words. Sounds like, Mila, you get ahead of it and you say, this can be hard. You create safety by acknowledging the elephant in the room, and then you come in behind and try to offer some support. Other learnings or other anticipation about what you might want to try on? Thank you, Harsha. Mindfulness eating, that exercise that Daphne walked us through. You can put a Thich Nhat Hanh or John Kabat-Zinn YouTube and try it on yourself. It's really a wonderful exercise.
I was just actually working with the patient where this came up. She was mentioning she just gained 20 pounds. So we're talking about, oh, so you've been stress eating. Like, so what have you been eating? So we did the whole 24-hour, thing. And then also, we found out that I asked her, did you ever talk to your doctor about this? Has this come up? She's like, no, but my doctor knows I've been gaining weight, but we've never talked about nutrition. Can I get a referral to a nutritionist? I'm like, yes, of course, we can definitely get that for you. And so because she doesn't know what to replace her foods with, she just knows she's not eating like properly at the right times. She's eating a lot of white bread. She's eating a lot of sugar. So she said she was happy to have that conversation. She's wanted to talk with someone about it for a while, but she just hasn't because she's got a lot of other stress going on in her life. So I think it was a good conversation with her.
And Dr. Huang, you're on the mental health side of the house, right?
Yes.
You're a behaviorist.
Mm-hmm.
So that's fantastic. I mean, the food and mood and the metabolic health is really important. That's why we do this integrative work together and bring teams together. And that's really, I think, what Bach has done really well in bringing multiple teams and willingly and so excitedly bringing everyone together to learn from this. So hearing your story there is powerful, and that you're paying attention to that. I think part of what we're trying to accomplish here is that not all clinics have nutritionists, right? And so we want to do 2 things. We want to give a baseline entry point for those who've never been comfortable with the nutrition, to integrate that. And then to also bridge into working with your wellness team and nutritionists, but then also have an integrated understanding. So nutritionists and the clinical teams, the behavioral teams have a similar language that they're speaking and pathways of what we're trying to do together. So thank you for sharing that, Dr. Wong. Other things are coming in. Wow,
There's
Dr.
so many
Hamed.
good things coming
Yeah.
in.
Challenging them to try one meal first that they will add that is homemade, and seeing if they actually enjoyed it. Yeah, and testing that out and what was better specifically. Ronald's talking about color variation. That's powerful, and using that with kids. Healthy food choices and meal prep. I find that meal prep's another big one. You know, Dr. Miller spoke about compiling last time. And when I think of meal prep, I think of compiling as well in preparation. Vey is from Native American Health Center. So he's visiting and listening in. Investigating how patients eat. Some don't cook. Exactly. They rely on others to cook. So then how do you bring in the family? Educate ways to bring the family in and strategies. So fantastic. Great. This is great, guys. There's gonna be some more interaction in the follow-up. So I'm gonna bring us back then to the deck. So
Yeah, just to comment on sort of a theme that I see emerging here that's really very inspiring for me is just trying to make things fun and positive. I think that so many people have kind of have had past traumatic experiences talking about food and their bodies when they go to see a health provider. And, you know, trying to focus on things that are positive and changes that can actually be fun to make, and focusing on, you know, deliciousness of food is, and, you know, not talking about weight loss per se, can be really, really a refreshing message for our patients to hear.
that's right. So we're putting it all together. We're going to do a section now what's about what do you do? And then I'm going to share my perspective, and it's kind of a mini me, so you can imagine being in clinic with me. And then we're going to do a little review, and to kind of do that review with images. So here we go. Remember the kind of pathway of disease, if you will. We have two interrelated pathways. Insulin elevation, right? Lots of insulin all the time, high frequency, high boluses of that insulin leading to resistance. It's showing up in resistance in the skeletal, the adipose, the fat, the liver, and different organs. You have direct hits from your fructose. It can be wine as well, or alcohol going straight to the liver, causing insulin resistance. We have our seed oils and other kind of processed fats that are in a lot of the baked goods that are leading to inflammation. So you get these two things happening, leading to these downstream metabolic issues that we're so familiar with. Diabetes, fatty liver, especially in our children now, obesity, cardiovascular disease, whatnot. We also know, and you've heard me say, work upstream in the exam room. We are all Sherlock Holmes, if you will. We're all investigators in the exam room if we're paying attention and thinking that we have moments for intervention. And I think that's the beauty of us in primary care, if you will, and FQHCs. We see our patients hopefully through life, and not sometimes at the end, but sometimes early on. And so we have something to offer now. From an insulin resistance perspective, you remember over time that you can see insulin kind of early on in the red spiking and then dropping a little, but still being elevated, and then glucose over time because of that drop elevating. And so early signs of hyperinsulinemia, PCOS, sometimes obesity, sometimes overweight, you know, depending on your phenotype. And we've talked about how size, outside appearance doesn't always translate to being unhealthy, right? That's the bias been, if you're obese or you're overweight, then that's unhealthy. Not always so, but you know, for a majority, for a high percentage, there is something about that, but we want to be nuanced about it. Insulin resistance starts to pick up, and we'll start seeing a bump in the blood pressure. We'll start seeing some pre-diabetes, fatty liver, and then kind of frank hypertension. Start seeing type 2 diabetes, and then heart attacks and stroke and all the other badness that happen. People will put in cancer as well, right? So we have an opportunity to work upstream in the exam room. The question is now what? You've gone through these trainings. We've gone through these trainings together. How are you going to integrate this into your practice? Which patients will you start? What are you actually going to say? So you've heard Daphne and I ask you questions. What do you actually say about, meals in, meals out? Because it's the language that you open with that leads to an experience with your patients. And then where do you start? Dr. Alameda talked about certain patients and starting with them and identifying what their needs were. What tools do you want to use? We've given a lot of information. We've tried to break it down in different ways. We've masked the learning and coming back and repeating it. We want this to stick. So it's not like you have to look it up all the time. So this is the opportunity now for us to talk as a team.
What to
And then,
stay?
yeah, so how are you all applying this? How is this sitting with you and your application to your clinics and to your patient care?
So Dr.
Maybe-
Chen, whenever,
Go for it.
oh yes, so my patients is the,
Sorry, Dr. Jimena, it's kind of breaking.
oh, sorry. Okay.
It's in and out. You want to try one more time?
Can now?
I can't. It's in and out.
Now?
Yes, that's better.
One of the things that I do with my patients is I usually gauge if they're actually in the mindset to talk about it, because sometimes that's not what they're there for. That's one. But sometimes just even putting in a little blurb saying, it seems like you have a lot on your plate right now. I really wanted to talk to you also about this thing, but we can table it. But I just wanted to think about it if that's something that we can, revisit later. Like, tips that you can do, small little they're even receptive, because sometimes they're not, and that we don't want to think. Usually the best time is when they're actually thinking about something to change, or if they're frustrated with where they're at, then that's when they're open to suggestions. But when they're not yet in that mindset, I try not to push too much, but whenever they're in mindset, you just jump at the opportunity whenever you see it, even if it's a small window. So
I love that. You're deferring to the patient. You're inviting them in to make decisions and raising questions for them to think about, instead of just kind of coming in telling them, hey, this is what you got to do, right? Thank you. How do you integrate R4H into your practice? Which patients? What do you say? Where do you start? What tools do you use? A. Espinosa, making a conscious effort to review dietary habits as it relates to diabetes and high blood pressure, especially if the patient's engaged. I like to write out some of the favorite foods of a patient so we can identify a few of their go-to foods and how we can adjust, modify, or focus on portions. That's beautiful. You may remember Dr. Miller we had a slide where we were talking about veggies, and she said, well, which veggies do you like? And then just having them start generating a list. That's how I'm hearing you do that too, A. Espinosa. You're really asking them to generate that list and then adjusting. So I will say that just as you do a 24-hour recall, or you spend the time in this conversation with your patients, it can eat up time, right? You only have 15 minutes. What I've learned for myself is that I now have confidence that this stuff is actually fairly important. And it's not just about adjusting my dose for the metformin from 500 to 850. It's not just about, making an adjustment on, or getting them into a lab test or whatnot. This is worthwhile, and it actually allows me to feel confident for me that I can spend a little time here. And then that's the visit, and that's a medical visit, and that's okay. It's justified. It just doesn't feel like we did that in medical school, but it's actually okay to do that. Others. Any of the wellness team folks, when you're talking to patients, have any experience, or how is this shifting how you're talking to patients? Or the
So,
coordinators?
Can I comment, Dr.
Please,
Chen?
Myla, please. We welcome you to
So,
comment.
so being a nutritionist, I really do not have to, I really do not have a choice on the patients that I will be talking to, because all of the patients really need nutrition one way or another. But occasionally I encounter clients that do not even know what do they come in with me. So usually I go back to, you know, the previous appointment with the provider. So somehow I encourage the patient. Didn't you remember your last visit with the provider? Your provider has a concern with regard to your diabetes, etc. So I'm also here coming in with you to encourage you with that concern of yours to talk with me about. So something like that. And then from there, I assess.
So you're kind of connecting them back to the intent of their provider, and then bridging your work with that work with the patient.
Yes.
Yeah. Thanks, Myla.
Thank you.
Does anyone have an opener? What's your opener for this? So Myla has an opener, right? She's going to bring it back to the provider and the why you were referred. Does anyone have any language they use as their opening line? All right. With that, then I'm going to go back to the share screen, and you'll see, you're going to have a chance just to hear how I'm thinking through it, right? And I'm just one of many people. Everyone does their own style, but we've also realized that it's helpful just to hear people who've been doing it for a long time and their patterns. Like when I talk with Daphne on this, I love hearing how Daphne's thinking. And I often call it mind melding. I'm like, oh, how is she looking at it? Oh, it's interesting. It's different than how I'm doing it, but I want to understand that. So I'm going to give you an opportunity to hear how I kind of do this work. And it could be Daphne, it could be any of us. So this is my initial approach, right? I'm kind of the Sherlock Holmes approach. If someone hasn't fully declared themselves with frank diabetes, CHF, CAD, depression, whatnot, from a metabolic perspective, I'm looking at these indicators. BMI, so-so, you know, because I recognize BMI is not the best. But if it's important to them, I think about it. I think about their glucose metabolism. You know, are they pre-diabetes? Are they not? And are they frank diabetes? I look at their blood pressure. You know, I used to be much more like, you know, just don't do anything until they're 140 and above, and even then kind of tolerate it. I start going more aggressively and looking at where they're at, just to kind of create curiosity and a possibility of shifting. And then I look at the lipids when I have labs, just together, really, and I'm looking at this triglyceride to HDL ratio. LDL is important, but I often use this to help me understand where is the patient metabolically, because if they're in a very unhealthy metabolic place, then that LDL means a lot more to me. If they're very metabolically healthy, it can mean something, but maybe not as much. And this is where there's a lot of interesting research and thinking going on in terms of lipids, but it's not your standard kind of start everyone on a statin approach. So then my opening, especially if I have labs, I say, interesting. You know, I'm noticing you, and this is the Unwin opening, right? I shared this with Dr. Unwin, the guy in England. You know what? You may need to be placed on lifelong meds to treat this condition. Would you be open to an alternative? And I just pause. Lifelong meds is something most people don't want to be on. And so it just kind of opens that. And then I kind of start something along the lines of, hey, to start with, we have a few approaches. You can do one or two of the following. We can talk about when to eat and what to eat, and kind of removing and replacing. And so when I'm talking about the when to eat, I don't go into each of these. I'm just listing them here, right? Time restricted eating within a 10 to 12 hour window, a 6 to 8 or a 4 hour, no snacks. I usually start with this. I say, hey, well, where are they, right? For some of my patients that are really trying to aggressively move on their metabolic health, I might offer them the OMAD. That's usually that's after I've gotten them onto working on some of this and really ensuring there's no eating disorder issues. We've treated patients who have eating disorders, managing control issues around that, managing if they go into intermittent fasting just very quickly and some of the side effects. Again, fairly safe, but sometimes they get cold in their body or they're just sluggish. Managing the snack piece. So I spend a lot of time here if they're wanting to go with the time. And I talk about just really two things. It's the duration and then the frequency of eating. And I construct the conversation from there. This stuff is a little more for tweaking some of my other patients. If they're diabetics and I'm watching their sugars, adjusting their sulfonylureas, kind of preferentially reducing their insulin when I can, preferentially taking them off of the sulfonylureas, the glipizide, glycerides, and shifting them more to the metformins as needed. And so there's different ways to do the fasting, if you will. There's the 36-hour fast where you eat at dinner and then you fast until, you skip a day, you fast until the breakfast the next day because you sleep that night, right? So tonight I eat at 8, I don't eat. The next day is at 8 p.m. I go to sleep at 10 or 9 or 11. I don't eat, and then I start my breakfast. That gets me a longer fast. It's lowering my insulin levels. So I really just start with this first piece. Well, where are you? How often? When do you start eating and when do you end eating? That's literally my first question. I don't even get into all the details in between. What's their start and end? It's, oh, that's your eating window. And I'll say, hey, how often are you eating during that eating window, including snacks and drinks? And then we say, oh, it's 5 times, huh? And then we talk about it. So then if that's not the pathway, right? Some patients I might open with that. Then some patients say, well, doc, I really want to know what to remove and what to eat. And so I often start with, well, let's remove the added sugars. An easy one could just be sugary drinks for the next 2 weeks. Can you just shift out to sugary drinks? And then there's always the question, and I often pair it. That's why I go remove and replace. Replace it with what? What kind of substitutes will I use for the drinks? If they don't want to do drinks, they want to work on the Netflix snack at night, right? At 10 p.m. they're watching Netflix and they're having popcorn or something. Maybe that's their processed carbs. And then we say, well, if you want to just cut it out and then shorten your window, you can do both at the same time. And then usually eat a dinner that actually has more of this fiber-filling veggies or more healthy proteins, fish-based, plant-based, unprocessed meat, healthy fats, throwing in some nuts, avocados, and then making it all taste well with the spices. So these are kind of like my 15-minute kind of intro. And I recognize I can't bring my patients back every week, right? When I'm in group, I can, like Erica can, or Daphne did this morning. So I just know that some of these shifts can be very powerful if they sustain it. I might send them to the nutritionist as an interim, if I have one at the clinic, to do some interim work, and then I see them in 3 months or 4 months. If they're diabetics, I'll bring them back earlier, especially if I'm managing their insulin. Let me pause with that to see, does that help you all get a sense of just one clinician's approach? And if it gives you a sense, what questions do you have about this approach? I fear that I talked too much at you guys, telling you what I'm doing. But I'm hopeful that you're just absorbing it and digesting it too. Questions?
I really like this approach. Dr. Chen, and but my approach might be a little different because most of the time the patients we are seeing, it has to be very personalized or customized. But at the same time, if I give them something like, the middle part, what you mentioned, they might not do it. So maybe like baby steps.
Mhm.
So I usually try to say like, okay, do the small, like portion size, control the portion, whatever you're taking. And I have a lot of Indian patients, so I remind them about the carbs intake in the Indian diet or the Asian diet in general, and how they can add more protein, and especially vegetarian patients, Indian vegetarian, and
Mhm.
what are the proteins that they can add. So more of like replacement. I focus more on replacing, not cutting the frequency that much. Because I think that, and being in internal medicine, I have more geriatric patients that they won't do it because they have done this for their life.
That's right.
I mean, I told my mom to avoid eating like, the roti or the bread at the night. And she's like, I cannot do that. I have done my whole life. I've eaten this. If I don't eat it, I'm going to fall. I'm going to have this passing episode, And so I know, it's hard to change the habits for a 70-year-old, 65-year-old person. So I just try to replace a little bit, like instead of having this much of rice and this much of, the vegetable, or, you just change it, make more of vegetable and less of the rice, or, cut it down. So that's the approach I take. But this is great for the younger patients or patients who are able to, definitely change. And maybe I should try that. When I was saying, I'm like, okay, I should try 36-hour fast myself.
Well, thank you, Harsha. That's so helpful. And you're illustrating the key point, which is I don't do all of this necessarily together. I lead with where the patient is. And if your mother was my patient and she was absolutely really focused on the removing and replacing and what to eat, that's where I would start.
Yeah.
And then I just know I have a pathway. I have 6 moves I can do when I bring them back and reinforce. And I can stay on one path, one move, one step for a while. For my elderly, I don't often go aggressively on the when to eat. I usually will say within your 12 hours, I kind of keep it at the 12. I'm not trying to push too much on the others, depending on, if they're on insulin or not. I might push it to 6 to 8 because I want to make sure they get enough protein as well, plant-based or otherwise, just because I don't want, their muscles to waste and stuff like that. So thank you. That makes a lot of sense to me too. Others?
My concern is with busy moms, Dr. Chen. So they usually, we usually encourage family meals, right? So when we take into consideration the intermittent fasting, so somehow it defeats the purpose. But my problem solving is that, again, it's baby steps with regard to food choices first, and then for sure their meal schedule is not that perfect too. It's not really structured. So again, I support with the meal structure, the 3 meals and the 2 snacks in between, and then again baby steps in going towards that intermittent fasting in the future.
Yeah, I mean, Milo, when I do the when to eat, some of my patients, one of my moves is just to get it down to 3 meals, no snacks. Because I'm just literally, I might keep the 12 hours. I usually try to keep them at 12 because the American population has tended to go to 14 and 16 hours from start eating, drinking to all the snacks and things in between. So then I just say, hey, can we go to 12? Because that's pretty much safe for everyone. And then I say, within that, eat your 3 if you want, but maybe we can cut from 5 down to 4 or 4 down to 3. Because you don't necessarily need the snacks if those 3 meals are actually adequate and nutrient dense and filling, if you will. And that's where then I would start dialing into what. I am trying to move, my preference is to move people off the kind of the pathway of small meals throughout the day and more into kind of creating moments so that the body can rest, the insulin can drop down, which is different than, traditionally with, depending on what school of dietetics and nutrition, the past has often been like, just graze throughout the day. But I think the metabolic concern around that, especially given our food environment, is that you're just spiking insulin every time. And the insulin has a time, it doesn't drop down over so quickly. It hangs out in the body. Milo, what do you think of that as a response? Any reactions to that?
Yes, you're right. 12 hours. And you're right about snacks as needed, really. If you have 3 main meals that are adequate, I think that's the way to go. Especially for, again, clients with exceptions. Very active, busy, construction type of work. On the other hand, there's this people with eating disorder. So somehow that's also different.
Definitely. I'm very careful, in the group that Daphne is seeing at Lifelong. When I was seeing patients, I had a number of patients with eating disorders. And so I'm very careful because there's a lot of issues around control. And it's that fine balance between accelerating so much control, they go to totally zero, like they get very particular to the minute, and it stresses them out, to just saying, you know what, let's give a structure of 12 hours. And then, have 3 healthful meals. If you want a snack in between, fine, but let's start at the 12. And I tend not to push to, anything less until I really get to know the patient and I know where their goals are. Because I really want to get to the underlying, and this is what Marjorie was saying earlier. What's driving some of this? What's the trauma that's underneath, potential trauma underneath the eating disorder? Or what is the mindset around body image that may be there? And so for me, a safe place is just creating some structure instead of kind of yo-yoing from, totally splurging on food to totally nothing, right?
Nothing.
So I try to really keep it simple for folks with eating disorders, but I'm very gentle, and I really want to assess where they're at with that. Others. Okay, we're going to move then into the next.
I do want to add too that, Dr. Chen just mentioned the Recipes for Health group, which, nominally is around dietary change and, healthy eating. But there are folks in that group who set these goals every week of doing things like, I want to finish that Afghan that I've been crocheting for the past 6 months. Or, I want to look at where I might be able to go back to school next week, to learn, I want to go back to study something. And I think just having it be a place that's super positive and exciting, that these changes tend to trickle down to other things and overflow to other things. So the conversations don't have to be about diet and food necessarily. They can be about wherever that patient would like to start to make changes, and it will have, it will have positive repercussions in lots of different ways.
Thanks, Daphne. So I know it's 12:07. I suspect that folks may want a bathroom break or a quick break. All right, well, let's begin. So this is going to be super interactive. I would love for people to quickly, this is very much a high-level review, but hopefully crystallize with images to help you know your moves. So here we go. I'll pull this up. A second. Oh, I moved my screen now. Okay. All right. Is everyone back? What's in our spectrum of 6? Oh, hold up. Jumped up here. All right. Here we go. In our spectrum of 6, let's start with the first one. Doesn't mean you have to start with this, but what's the first move or the first step on the spectrum? Anyone quickly say it out loud or type it? Oops, I just gave it away. Well, it's there. So basically you decrease the sugary drinks, right? Or you can lead positively, increase the water, teas, and coffee. You could spend a visit just doing this. If you took out people's sugar and alcohol and all of that, and you made that shift, that has great metabolic consequences. So that could be part of your visit if they're willing to go there. What's the second step? Carbs. Erica, you got it, right? So increase fiber, right? So second step, increase the fiber, the veggies, the legumes, pulses. These are all veggies, right? Whole grains can be considered a veggies, plant-based. again, you don't, there's a little caution here on the whole grains, right? Because it's tough to find whole grains sometimes. And it's not necessarily that you have to have whole grains, but if you're going to have grains and make them whole, oops. And then decrease the processed carbs. So Sapna, Dr. Jimena, you guys all have it there. All right, what's number 3? And you want to have these ready to go. There you go. Our mojado got it. Remove the processed meats, replace with the unprocessed. So we led with the processed carbs. We're going to now kind of talk about increasing the unprocessed stuff, right? Meats and seafood and fats are actually okay. We've talked a lot about that, depending on your metabolic, kind of where you are metabolically. But you can't go wrong by decreasing the processed stuff, the tasty stuff that we often have, fast foods, these type of oils, the seed oils, the dressings that slide into your tons of veggies, right? So you have that down. Great. And then what's step 4? You got it again. Oh, actually step 3, there's one more for step 3, because we broke this out a little differently. Something about making food taste good. Spices, there you go, Erica and Armando. So add spices for taste. There's a lot of medicinal properties. Remove the excess salt. And there's some debate as to, like, you know, how much of the salt, 2/3 to 1 teaspoon, you know, that's the kind of general recommendation. We tend to get way more than that in our processed foods. So that's a simple one. You could spend a visit doing this. Number 4, it's all about when to eat and what to eat. So 2 things: shorten your eating window. We just spend a lot of time on that. And most of us are kind of at 7. A lot of people are 17 or 14. We can stay safely here. Here's a progression if you want to move, depending on how fast you want to move with each patient. Some patients will go down to the OMAD, if you will, right? Or a 4-hour or OMAD, or 2 times per week, or the 36-hour, right? And then the frequency, and this is what I was speaking earlier to Mila about, right? Because I think apart from pregnant women, in general, even children sometimes, right? They get hungry, their metabolics are different. But in general, 3 meals without all the extra snacks in between, if those 3 meals are good, you're good. It could be 2 meals too. All right, number 5. What's the 5th one? There you go. Wow, our mojado, sorry, I don't have your first name, but just reading off the chat, you are on it. So the 3 C's, right? Cook and compile, the contemplate, as Dr. Miller was going through, and the chewing. And that really can help with the ghrelin and the leptin and the hunger hormones, all of that. And then number 6, last move. So this is just to remember the image of maximizing meals in with family. You can always remember Daphne and her Japanese host family, right? And minimizing the meals out. And then just any restaurant food, even if it's high end and low end, whatever, there's some concerns around what's in that food and the impact on your metabolism. All right, that's a quick review. You have this. You've got all 6 of these. You can move any way, any which way with your patients. You can dance any type of dance with them, right? So you have these available tools. So then I wanted to just kind of to spur the thinking, to hear from you all. What framework, concepts, and tools have been helpful? Aside, you know, we just went over the when, what, and how. We talked about those. But if you recall now, over these trainings, is there any tool or concept that's been helpful to you all? And I'd love for people to chat away or to just answer. This is all about integrating and kind of making sure the information that came in is actually now being able to work into your body, and you can say it, talk about it. The hand is a portion size gauge. Fantastic. So serving sizes as a concept. Thank you, Dr. Jimena. And this is what I mean by tools. Personally, being mindful of reading the nutrition, so label reading, right? You don't have to teach everything. I'm not as worried about calories, right? I know someone said calories, and I purposely didn't put calories in there. I'm more worried about the metabolic impact of calories than calories themselves. Your data that shows less meals per day was enlightening. Thank you, Phyllis. Yeah, definitely. less meals out, or just less meals, depending on frequency. Other concepts. You're going into clinic at 45 minutes. What has landed for you and what is not? Asking for yourself what you're feeling before munching. Yeah, that's that whole pre-contemplation stuff. What's and understanding it a little of that. And how do you translate that to your patient, right? Maybe a patient who has eating disorders, that's a place to begin the conversation. Or the person that Marjorie was saying, for example, who needs a little connection for what's driving some of the compulsive eating or food-based, mood-based eating. Great. So I'm going to list a few. Many of you have already gone over this: the when, what, how, plus the 6 moves. The 24-hour recall, right? That it's on a specific day in the last week. Don't make it some general thing. Something they can remember. The 24 added sugar journal. I think Sangeeta was asking about the amount. It's 12 to 25 grams for children, or 3 teaspoons. 6 teaspoons is 25 grams, and 38 is the 9 teaspoons. Adrian says, listening to what your body needs, right? Listening, is it water, maybe for the hunger, or fruit and vegetables? Sangeeta is talking about preparing your own meal. So meals in, fantastic. Keep on going, guys. Serving size baselines, just as reviewed, like Dr. Jimena, the serving size, the fist, or you can do what Daphne was showing you earlier around, like for the butter and the oils in your thumb. The teaspoon of 1 salt, 1 teaspoon, 2,300, 2/3, about 1,500. These are estimates. The deck of cards, right? Or the size of your palm, just 2 times a week. That's the kind of recommended to get your standard omegas. And then specific, this is where I say getting a little specific. It's not enough to say eat more vegetables. Ask them what vegetables they want. And then what other foods are they incorporating? How about the smashed fish? You all remember what smash is? Salmon, wild salmon. M for mackerel, not king mackerel, but the Atlantic mackerel. A for anchovies. S for sardines, there you go. And then H is herring.
Herring.
I think it's herring, oily, small fish, high omega-3. And then the MUFA cooking oils, right? Avocado oil, olive oil. All right, so we're done with this. That's the clinical portion. We're going to get into healthy eating patterns. And so here we go. This is the stuff that you hear about in the literature and in science, but we're going to kind of go deep into that, or touch into that, and then come out again. And so there's 6 kind of patterns that are out there that are recognized eating patterns. Sometimes they call them diets that reduce insulin resistance and inflammation. The DASH diet, the Mediterranean diet, the MIND diet. I don't know if you've heard of that. I think Marjorie might be interested or may know about that. Whole food, plant-based, sometimes known as vegan. We've talked about that, but really whole food emphasis. Low carb, high fat, kind of a ketogenic diet. And then kind of broadly speaking, ancestral or traditional diets. So we're going to go through the evidence behind some of this through a case. So I'm going to turn this over to Daphne, to Dr. Miller, to start us off with this case.
Let me unmute here. This is Mrs. M, who's 65 years old. And she comes in, she tells you that she was recently diagnosed with stage 1 hypertension and prediabetes. And she wants to try lifestyle changes before starting medication. So she is actually asking for advice about food, which I know you guys have as your first rule for wanting to engage with folks. And she says to you, what are the differences between the DASH diet, the Mediterranean diet, and the MIND diet? Which of these will be most effective at lowering my blood pressure, blood sugar, and helping me with my memory issues? So how would you advise Mrs. M? And by the way, Mrs. M says that she loves Filipino food. And are there any diets that, which of these diets might she be able to incorporate some of her favorite Filipino dishes into? So thoughts before we get started? How would you advise her between these diets? How can she bring in her favorite Filipino recipes?
Maybe it'll spur some ideas. Let's go through the DASH diet then and Mediterranean the
Yeah.
mind.
Why don't you take it away from here, Dr. Chen, and tell us the difference between these diets? Because I think we're a little confused.
Yeah. So DASH
At
diet,
least I am.
we talked about DASH diet last time, right? It looks like this, right? It looks like a lot of veggies. This one has a lot of grains, actually, whole grains, hopefully. You know, some dairy as well, some fats and sweet that are limited, fish and protein-based meats. And then I think that one of the key pieces of the DASH diet, because it's American based, it's often like gets into the milligrams, right? And this is where we get the 2300 or the 1500. And then really the key thing is what's the evidence behind it, right? And so you can feel assured that if you put someone on that kind of that type of spread of food, you're going to see a significant drop within 2 weeks. Combined diet, they tended to use low fat, right? So this is kind of the older approach, low saturated fat, which is still viable. It's still okay as long as you're not replacing with sugary foods. And you'll see a substantial drop in systolic blood pressure within 2 weeks. And then even on the diastolic end. So part of it is saying, okay, well, DASH diet, you know, we don't need to get into all the details of how many servings, but just know there's a lot of the stuff that we've been talking about, more veggies, some of the whole food based meats and proteins, fish, and they add in some dairy, right? And they kind of keep it low saturated fat. Well, what about then, and it's in 2 weeks, you can see this. I mean, this is very powerful. What about this Mediterranean stuff, right? Mrs. M is like, I'm Filipino, right? I'm not, what's this Mediterranean stuff, right? What part of the world is that? There's no universal standard. What do you see when you see this picture? Does it look fairly similar to the DASH diet? I don't get technical, right? But if you were to kind of try to read the serving sizes, it'd be less meat, rare sweets, poultry, chicken, or poultry, eggs, cheese, and dairy, right? Similar to DASH, right? Some cheese and dairy. More emphasis on fish and seafood. A little more than DASH probably on this here. And then a bunch of assortments of veggies, nuts, seeds, fruit, all this kind of plant-based stuff with some healthy, unsaturated oils. So the question is, great, I've heard a lot about it. I don't know what part of the world it is, some part in the Mediterranean, where in the Mediterranean. What's the data, Dr. Chen? Is there anything behind this? You know, DASH diet sounds like there's some good data. This is pretty powerful if you use it for a coronary artery disease. This is the Lyon Diet Heart Study. It's a very important study. It basically was a randomized controlled trial for folks who already had heart attacks. And it was looking at these patients who had heart attacks in the hospital, and they're given a Mediterranean diet versus a Western diet. And these folks already had heart attacks. There was a 72% less cardiac death, right? So the people who were eating the Mediterranean had less death and repeat heart attacks than people who were kind of on the standard American diet, the SAD diet. It's about tracking people over 4 years. 423 stayed into it. This is all before statins, but it was a very powerful study. Similarly, it could reduce diabetes onset. This is a Predimed study, and basically tracking people who are already at risk for this over 5 years. And they saw that the diabetes incidence decreased in those who were on the Mediterranean versus who were on back in the day, they talk about low-fat diets, which we know is not really the pathway to go, right? There are elements of other dietary patterns which can be low-fat, but it's in context. So cardiovascular disease, diabetes, powerful evidence. 418 non-diabetic patients they were tracking to see if they would develop this diabetes onset. What about the mind diet? Because she's asking about her mind, right? Like her own cognition. What do you see here? What's distinct and what's overlapping?
Let's focus on brain health.
You got it, Mila. And it takes pieces of the Mediterranean diet. It takes pieces of the DASH diet, and it really adds in berries and leafy greens. That's why there's this brain here with greens and a lot of berries. The antioxidant element of that, there's something about these type of foods that have been really helpful for metabolic health of the brain. And the brain is another important piece for metabolism. Now they take a different approach when it comes to butter and margarine. They're kind of taking more of a low saturated fat approach, less meat, less fried food, certainly that's processed fats, and less sweets. So there's some overlap.
What's dairy overall, Stephen? How about just dairy in general?
Yeah, I don't think it's not a main emphasis for them. So I don't recall them. I'd have to review that again to see like dairy itself, like the servings and whatnot. But
yeah, my recollection is that it's much less dairy in general, sort of not.
Yeah, that's my recollection too. I just don't have the serving size info on me readily. So in terms of the data, which is interesting, right? MIND, and this is their acronym. They're always funny acronyms. Mediterranean DASH, it's combo, intervention for neurodegenerative delay. So we're going to see a tsunami of this. If you haven't experienced it in your own lives with your own parents or uncles and aunties, or just your own patients, our elderly generation is getting a lot of pre-dementia, what we call MCI, mild cognitive impairment, which is a pre-dementia state that could go into full-on dementia. Patients who are on this type of diet, they've done some looking at this, and this is all observational, but it's important for us to be aware of. There's a lot of active research happening here. It can reduce the risk of Alzheimer's disease by 53%. How do they get there? They're tracking people over 4.5, 5 years and extrapolating, and they're saying for 3 groups of patients on different levels of the MIND diet. So the tertile 1 here is people who just kind of do it, but not too much. Tertile 2 is, wow, they're pretty good. They're actually adhering. And then tertile 3 is they have the highest adherence and the most of the MIND diet type food. And that this reduced the risk substantially for those who are the most adherent to a MIND type diet, as well as for those who are medium. Now, again, you'll notice that myself and Daphne, we don't get into the details of how many servings and which diet necessarily, because at the end of the day, these are all controlled studies, in settings, and we're in real life in primary care, really working with our patients. The key thing is to get the principles and then to adapt it as needed. So when I'm looking at my elderly patients, I'm kind of moving them into, especially if they're having some cognitive issues, more leafy greens, more of the berries when possible, cutting out some of the processed stuff. All right, so Mrs. M just has gotten through those 3, and she's going to come back, but we're going to have another case. So I'm going to turn this back over to Daphne.
So our next case is Mr. Y, who's 52 years old. And he has actually experienced an anterior MI, an anterior heart attack in the past. He now has a stent. He's on multiple medications. He also has some worsening chronic kidney issues. And I think it was it Gemma, Dr. Gemma, that said that, some folks are just like, oh, my fate is sealed. I don't want to make any changes. Was kind of one of those people. He came in saying, I feel like, my fate is sealed. There's no dietary or lifestyle changes that are going to help me at this point. I have my stent. I've had my heart attack. I'm older. and that he might just continue eating his fast food and drinking sodas. So what kind of hope can we give him? What can we tell him that changes might offer him? Or do we tell him, at this point, just, it's too late, just continue? Not seeing anything in the chat. All right. So let's turn this over to Dr. Chen.
All right.
Is there anything that we can offer Mr. Y as a ray of hope?
Well, I'm going to use this as a case to read into or to lean into, or just to share another pathway, right? So this whole food plant-based diet, what is it? It's eating all the plants you want, really, no calorie restriction. It's formerly vegan, but vegan now can have vegan cookies, and that's not a whole foods. That would not fit for a whole food plant-based. So the whole food plant-based approach is really whole foods that are plant-based, and it'll have grains in there considered as plant-based. So in terms of some of that data, this is really powerful and revealing. Dr. Dean Ornish kind of led a lot of this work maybe 15 years ago, and he combined his whole food plant-based diet, not his, with group visits, kind of like what we're doing. And he showed heart disease reversal. In year one, he's had 2 studies. These are small numbers, but they're powerful because they're fairly deep studies. Within 3 weeks, there's reperfusion of the coronary arteries for patients who are on whole food plant-based getting group support. 82% of the patients had blockage reversal. And then over 1 year, 91% less frequent chest pain. So it's not over for Mr. Y or anybody who's end stage. People think food as medicine is only about prevention, for people not getting disease. In fact, you can have pretty significant disease and do well with this approach. Year 5, he followed this work and he saw consistent improvement. There's a whole bunch of data on episodes of chest pain, episodes of events, and whatnot. So you can look it up. The other piece is this Mr. Y has kidney disease. And so you may recall our kind of relative risk approach, and there's some systematic reviews which show that end-stage renal disease for the patients who are on whole food plant-based diet, it's less than 1. And that favors basically a lower protein diet. That favors them having slowing their progression or their decline of their kidney disease. Remember, at 1, it's balanced, and then anything above that is worsening. And I've tried this, and there's a nephrologist at Sutter who's kind of department chair, and he's been doing a lot of interesting research and looking into this whole food plant-based approach for folks with CKD. I think we have some Marjorie saying, validate him, discuss his concerns, give him examples of other patients with similar conditions. Absolutely, providing hope and pathways of others who have done it. Thank you. We're going to get to some of the other comments in just a moment. So now I'll just turn this back to Daphne, since you're doing our cases.
So Mr. Y comes back in, having learned about the ketogenic diet from a TV show, and is really interested in this diet and says, would this be safe for me? I'm wondering if this might be the answer to my problems. And it sounds like a pretty tasty diet, because I heard that I could have some bacon with it. So what would you tell Mr. Y about the ketogenic diet? Does anybody use this with their patients? What is the ketogenic diet?
Let's go into that. What is? So there's a lot of information, just like intermittent fasting. There's keto. There's lots of information coming out. What is a low carb or ketogenic diet? Let's start with just the standard stuff, right? So the standard diet roughly standard American diet, 225, 325 grams of carbs, if you're counting, right? But just so you have context, it's a lot of carbs. We eat a lot of carbs in general. A low carb or to a ketogenic is saying basically 20 to 50, more for a strict, of net carbs, high fat, and then moderate protein. The ketogenic approach is really about modulating, really being intensely focused on insulin management, insulin spikes. And so that's why they say high fat, because in general, fat doesn't cause insulin to spike. And then protein, it does. That's why it's moderate, so not tons. It's not like an Atkins diet where it's all about protein only. And it's actually surprisingly to many people, because they hear keto and they think fat only, it's only about bacon or whatnot. It's really about unprocessed meats and seafood and lots of veggies. And that's what I think people forget, because people think low carb means you just don't have carbs. But carbs are veggies too, or veggies are carbs too. They just have a lot of fiber, so their net carbs is often lower. And so people often forget that and think it's all fad-based and whatnot. So I want to spend a little time, a few slides on the keto diet, just so you have awareness, and especially if patients come to you and want to try things on, and then we'll come back to Mr. Y. Kind of fundamentally, the keto diet, if you will, is more high fat, low carb, because we're managing insulin. And when your insulin is low, you start using up your fat, because your carb stores in your liver and your glycogen and all of that is used up. So you're using now kind of a hybrid car. You've shifted from glucose to ketones, and ketones are often used to feed your heart anyways. And now you're using it to feed your brain and other parts of the body. And that's different than our standard American diet, which tends to be the high carb and this kind of low fat emphasis, which often increases the insulin either by frequency or just boluses because of the types of carbs we're eating. And we just focus only on glucose. And when we have high insulin, we're in fat storage mode. That is a metabolic switch. That is a hormonal switch. You cannot reduce fat if you have a high insulin environment, because it's basically telling you have a lot of food in your environment. And so your body is evolutionarily designed to store. And so we store. So that's the background behind it. The benefits, you can do a QR code. We didn't go into all the details. This is a systematic review. But in general, it's showing diabetes improvement. This is significant. A 1% drop is significant. Anything above 0.5 is significant clinically. Fasting insulin and insulin resistance, again, that's one of its hallmarks, is to work on this. There's lipid improvement too. I do want to caution on one piece, and this is where we'll go back to Mr. Y. The lipid improvements we see are reduced triglycerides and total cholesterol and increased HDL. There are some patients that are hyper kind of responders. They actually go up on their LDL. So the LDLs go really high. And then that scares everyone, because we all know that LDL in general, there is a relationship to plaque formation, and we worry about too high LDLs. Anything above 190, we tend to, worry about familial hypercholesterolemia and wanting to treat that with a statin. The nuance here, and I think the opportunity as we look at this field, is to say, what's the environment in which that patient's LDL is landing? Because LDL from your lipid panel can't tell you the particle count, it can't tell you the size or density. And those elements are increasingly coming out to be important. So you may have someone who's a hyper responder, their LDL pumps up because they're on a keto, but everything else looks great. Their triglycerides or everything drop down, their HDL goes up, their hemoglobin A1C drops, their weight reduces, blood pressure goes down. And so then you have a choice point, and you need to think about that with your patients and understand where they are at. So blood pressure as well. So Mr. Y, really the question we would say is probably not go with the keto, because Mr. Y already had a heart attack. He's not primary prevention. He's not the diabetic or the pre-diabetic or the person with high blood pressure who has not had a heart attack or stroke. He actually had the heart attack. And because of that, we suspect his metabolic health is not very good. And if he does bump his LDL, it may be that his other particles and everything are not as good. So there's some caution. There's no clear slam dunk to say, there's just caution around that for someone who's already had an event around keto. I think that's going to change over time. We'll get more nuanced. But that's what's coming up. Daphne, do you have anything else you want to add on that? Okay, I'm gonna keep on going. 12:40. Just to give you all, if your patients, it's tough to explain this sometimes in clinic, so I often refer them to Diet Doctor. It's a pretty well-balanced website for those who are kind of wanting to get into it. And it really explains kind of visually how to do this in clearer ways and patient-centered ways. Just so the visual low-carb guide. So I'm going to give this back to Daphne to do Mrs. M, who's back.
So I just wanted to come back to this instance because I so often get, questions like this. And I think that you guys saw the sort of similarities and differences between Mediterranean DASH and mine. But there really are some pretty powerful themes that run through these diets, right? They have way more in common than they have differences. What are some of the things that you see as commonalities between these diets?
The increase in vegetables.
Increase in vegetables. What else?
The limits on saturated fat, trans fats.
Yeah, certainly the trans fats and highly processed foods, for sure. And maybe thinking of saturated fat as something that is, should not necessarily be the cornerstone of your diet, that it's a little bit more there to make all the vegetables taste good, right? The bacons and the red meats and so on are really used a little bit more to enhance the other foods. They're not considered wrong, they're just there. So limits on, for sure, on highly processed foods. Focusing more on whole foods, whole grains, beans, seeds, nuts, things like that. And also using dairy a little bit more as a complement rather than the centerpiece of the meal. Would you agree with all that? And there's, slight differences. One has a little more dairy, a little less dairy. DASH diet, dictates a little bit, more about in terms of salt content. But when you start to look, is the next slide our, what is our next slide?
Yeah.
Yeah. When you start to look at healthful diets from around the world, they also follow these rules. And so anybody here know what this is? Anybody want to chime in?
We got Filipinos in the house. They can tell us more about this.
Come on.
Kamayan means using your hands.
Yeah, kamayan, and it's this beautiful, fresh, vegetable heavy, delightful both way of eating, but also the contents of it. And so, this is something that actually I learned about, fairly recently, because I had so many patients who were of Filipino descent who told me, oh no, I can't eat my food anymore because Filipino food is just not healthy. And I think that was a stereotype, of fried foods or what have you. And I found out there's just so much healthful food that is traditionally Filipino, and the same with so many things that we get in the United States, like Hawaiian food we associate with Hawaiian barbecue, that the fast food chains is sort of how we think of it. And yet traditional Hawaiian food is some of the most healthful food on the planet. The same with, many, many diets. And so, yeah, the Kamayan diet, or what was included in that photo, is absolutely equivalent to the DASH diet or the Mediterranean diet, or the veggie forward diet, in terms of being incredibly helpful. Any thoughts or comments there?
I want to lift up Adrian's comment earlier. He had written in the text on this that really speaks to this. a lot of Filipino dishes use a lot of sauces, right? Mostly it has salt and sodium. So he was suggesting maybe cooking the adobo using less sodium soy sauce, or more spices like peppercorn, bay leaves instead of maybe, and maybe vinegar lemon, protein using more leaner meats, if you will. So there's ways to adapt it. And so, yeah.
And I also just want to add that eating with your hands, which is not something we traditionally do in the US unless we're eating a burger, but eating with your hands also is this form of mindfulness in terms of actually having contact with the food, licking your fingers, just the pure joy of it. And I very much think that that's something that when you look at a lot of traditional diets around the world, they are diets where hands are used more. I was raised in Morocco, and there we eat couscous and, you know, a lot of foods, the same thing with your hands. And that's something to contemplate too, just, you know, getting into the, you know, not just what we're eating, but how we're eating. And of course, that this is a lot of people, you can just see they're having fun together, sitting around and talking and connecting and enjoying, which is also very critical.
I suspect all communities have their, and cultures have their ways. And if you look at where the food was grown, as opposed to the way the food is grown now. And so Native Hawaiian, there's just one in Waianae's small study in 3 weeks. Traditional foods that we normally think are not, quote, healthy, actually lost 17 pounds, cholesterol reduction, 14% blood pressure as well. So this is just to put that, this other slide is just to say that many times, you know, if we use a critical kind of critique of the Mediterranean diet, and if you look at the history, there's an interesting article that there's kind of a racialized lens sometimes, like what is considered Mediterranean even though the Mediterranean area includes North Africa and parts of the Middle East, that's not how we often associate Mediterranean. We think of it as Italian, and there's a whole history piece here. And so
and just to be very clear, that the reason that that specific Italian Mediterranean diet is upheld is not because of RCT, where they identified that as the most helpful. It really started with Ansel Keys and his own voyages, where he really liked Europe, you know, and he was serving in the military in Europe, you know, and that's really where a lot of sort of our concept of the Mediterranean diet comes from. But when you start to look at it historically and in terms of kind of the bias that's been there, even in modern nutrition sciences, you realize, like, why are we not talking about traditional, you know, the African, countries and wonderful diets that come out of South Africa or West Africa or East Africa? Or why are we not talking more about other, Asian diets, other than, I feel like the Japanese diet gets a fair amount of love, but other than that, you know, it's sort of these universal healthful diets. And a lot of it really does not have to do with research. It has more to do with actual, cultural preference that was given to Western academic institutions.
Right. And so systemic racism it gets played out here as well in terms of food and food politics. So there are many pathways to health. You've seen that here at Kamayan, and if I'm saying that right, and other Mediterranean and whatnot, Japanese diets and whatnot. You'll see that there's a lot of overlap, right? We didn't put in the keto here, but there's, in terms of other patterns that are out there. You've also seen that there's some, benefits and on particular conditions. I'm going to qualify this one. There's a lot of greens here. When it comes to keto, there's a little red mark here that's demonstrated harm. I actually going to put a question mark there because of the metabolics and the nuances that are coming out around that. I think once we start looking at some populations, that may change, but we'll see. So that's to be borne out. If we go to this last case, this 28-year-old, we have Miss D, and she's like, I experienced bloating and gas after meals, right? Since she was a teenager, and she's been told she has IBS, her celiac panel is normal, no red flags. So what would you recommend? She's IBS, this is very common. Any quick recommendations?
And just to say that the reason we threw this case in, we're kind of moving away from this idea of different, meta diets, but this is more to illustrate how you can use healthy eating in practice to address more specific complaints. And, specifically, for example, IBS. So using it a little bit more as a symptom management tool for more chronic symptomatic complaints.
So Dr. Amanda, fiber intake, yes, may improve her gut flora and balance her gut health. Where are you going to get the fiber? Maybe some from the veggies. So we're going to share, since we have 8 minutes, I'm going to share something called the low FODMAP eating pattern. A lot of GI docs use it, but this is, once you have an understanding of fiber food as medicine, you can start applying this. And the question is, what is FODMAP? Such a weird, name, right? So just at the kind of acronym level, it's really about short chain carbohydrates that are resistant to digestion and basically cause a lot of gas and a lot of diarrhea and the symptoms that we see with IBS. But it's fermentable, oligosaccharides, so it's short chain, disaccharides like lactose, monosaccharides like fructose and apples, and then polyols, these are sugar alcohols like in your stone fruit. The idea here is, wow, wait, didn't Dr. Chen and Dr. Miller just say eat a lot of veggies? Well, for some patients, and this is where we get nuanced and refined with IBS, some of those things don't help, right? And so then the question is, you got to navigate that. And this is on our website. We have our patient community resources, the handouts we develop. This is adapted from the Stanford Low FODMAP Clinic in terms of the foods to eat and foods to limit. The idea here, thank you, Daphne, for sending that. The idea here is just know that you can have eating patterns, but you got to customize it. And your patients, even though we have 6 moves and we say in general, eat more veggies, if they're having IBS symptoms, you might have to be a little more precise about that.
Yeah, I actually just sent everybody another chart that's super easy to read that sort of has the foods
incorporated there.
Yeah.
So, the low fat, in terms of some of the data behind it, there's been reviews, randomized trials, non-randomized condition trials. In general, it's people who go off of this precision increase quality of life, decrease IBS, decrease symptom scores, and that there's substantial benefits potentially for Asian and Mexican populations when you break it out in subgroups. So again, the point here is just that there's more than just the eating patterns, and there's more than that's really about customization. So
can I just add one quick thing about that, just sort of in terms of my practical experience. I use this a lot because I do see a lot of midlife women with pretty severe IBS symptoms. And if you will see that a lot of the foods that are on the don't eat list actually are foods that are high in fiber and very good prebiotics. They actually feed good bacteria in the gut. So the idea is not to take these foods out long term, but actually to take them out short term so that patients feel better, and then have them just kind of slowly add them back in bit by bit. And usually what they'll do is actually start to develop more of a tolerance to these foods once they add them back in. So the idea is not to eliminate them permanently, but to help patients reset and then add them back in.
Great point. So we have this whole section on where the food comes from, but we have 5 minutes and we're not going to go too deep into that because I want to give you guys a chance to fill out the survey. But I will just say that, you have and I will close with this case of an 18-year-old, Miss F. She has a family history of badness, diabetes and heart disease. She's like saying, well, I really care about the world too. Like, what's the sustainable diet? What should I take and eat? And you may recall this slide. We talked about a planetary diet, which is, generic, if you will, and saying this is melding human health with sustainable health and planetary health. So it's just these recommendations from the Eat Lancet report, the types of plant source proteins, the types of animal source protein. I'm going to now fast forward. We're not going to get into all of the different types of farming and all, but I want to fast forward to, there's a bunch here, just to the model. Like you all may recall, at the end of the day, we've been with you on this journey for Recipe for Health. You have a food pharmacy at your hand, both the one at the clinic as well as the Recipe for Health one. You have a behavioral pharmacy that Erica is running. And then you've completed the 4 trainings for clinical nutrition education. We've done all the workflow work. So we've done this all together. Write your prescriptions. It's going to lead to patient and community health. Just so you know, in all our clinics to date, we've served over 2,200 patients, and 460 have gone through the group. That's 23,000 bags of food, 468,000 servings. So you're all part of this movement together, and I just want to thank you all. I'm going to close with this and give you guys the last 3 minutes, a very short, it's a quick survey, it's a long survey. But please, in order to get your CME, you will want to do this. So can you see my screen still? Let me try it again. So make sure you can see my screen, right?
We can see the QR code, yeah.
You can see the QR code, okay. So please fill this out. We'll send you a PDF, and we'll put the video up next week once we do some editing. It'll be in your S drive, and we just wanted to thank you all for being part of this together, and I hope it's been useful.